Hi, very good morning. I am Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity with previous lecture series in neurology, today we'll be dealing with approach to lesions in motor system, that is pyramidal tract. Indirectly, the most common presentation as far as pyramidal tract is concerned is hemiplegia. So, approach to a person with hemiplegia, or we call approach to motor system damage or lesions in motor system, and how you localize that lesion and how you approach. We will dealing with, because you will come across in your everyday practice the most common neurological cases in your oral exams as well as in your theory. A full question can be asked on hemiplegia. As well as in your everyday practice, you will come across the most common neurological damage will be hemiplegia. So we'll be dealing with that. So pyramidal tract, we know very well. It starts from the motor area, which is present in the frontal lobe in a precentral gyrus region. From there are pyramidal cells in a cortex. We get axons fibers of those pyramidal cells, which becomes pyramidal tract. The fiber which converges at the internal capsule before it converges, that is called corona radiata. So this is from cerebral cortex. Then you have got a corona radiata, and where it converges in the internal capsule. After coming out from the internal capsule, in an internal capsule, it will be there in a genu and posterior limb, mainly in the genu and posterior limb, in a very small compacted area. And in a posterior limb, it will be related to thalamocortical fibers, which we call as a sensory fibers, going to cortex, coming from opposite side of the body. Then we have got an optic radiation, which will be going to occipital cortex. Then we have got auditory fibers, which will be going to temporal lobe. And then we have got temporopontine fibers, which are interconnecting fiber from temporal lobe to the pons. Then as the fiber descend down, it will be running in a midbrain in a crus, and in a pons it will be scattered, because the fiber which will be going from one cerebellum, cerebelloponto, and from pons to the opposite side cerebellar hemisphere, that is cerebelloponto-cerebellar fibers. So because of those crisscrossing fibers, corticospinal tract, ideally we call as a cerebrospinal tract or corticospinal tract or pyramidal tract, and that will be scattered. As it comes down into medulla, it is present in a pyramid which is in the anterior part of upper part of medulla, and at the junction of upper and lower part, the fiber will cross to the opposite side. Almost 80% of the fiber will cross to the opposite side. Some literature says almost 90%. So they cross to the opposite side and run down in a medulla, and then in the spinal cord is a lateral corticospinal tract, or we call as a crossed corticospinal tract. And 10% of the fiber which runs as an anterior corticospinal tract or as an uncrossed corticospinal tract. And both this tract will end in an anterior horn cell. Cross fiber will end on the same side of anterior horn cell, and then lower motor neuron will start, while anterior corticospinal tract, before ending, it will cross to the opposite side in an anterior commissure of the spinal cord, and then it will end in a anterior horn cell of spinal cord. So from that anterior horn cell, now we'll get a lower motor neuron which will supply. That will be alpha motor neurons, which will be supplying extrafusal fiber of skeletal muscles. So we have got a lateral anterior corticospinal tract. We have got a decussation of pyramidal. You can see here, and representation of our body close to the lateral sulcus will be face, tongue, then neck, upper limb. Then we will have a trunk, abdomen, and then lower limb will be close to the medial surface of cerebral cortex, close to corpus callosum. So that will be foot part will be close to corpus callosum, and that will be the presentation of a lower limb. And even a bladder center, that is maturation center, higher control will be present in that area. And you can see that fiber will descend down. They will cross at the lower part of medulla to the opposite side, and then it will end in anterior horn cell. This is upper motor neuron. Now the other group of fiber will not cross. 10% of the fiber will remain on the same side, and they will cross in the anterior commissure and then end on the opposite side of anterior horn cell. This is called crossing at the lower level. These are uncrossed fiber, but before ending they will cross, and these are already crossed fibers. So finally they will end on the opposite side, so they control opposite half of the body. Hence, damage to the pyramidal tract will lead to hemiplegia. So we are going to deal mainly with pyramidal tract, so that will be producing hemiplegia. So how you approach? So that is a corticobulbar tract. Then you will have continuity as an anterior corticospinal tract and as a lateral corticospinal tract. After decussation, this will be corticospinal tracts, while the portion which supplies to the motor cranial nucleus in the midbrain pons and medulla, we call those fiber as corticobulbar tract. We have got the fiber which is coming from the cortex to internal capsule. Those fiber we call corona radiata. They converge at internal capsule, and then they descend down. So we will have different portion, that is cortex and corona radiata, internal capsule. Then after internal capsule, the part in the midbrain pons and medulla will labeling that as a corticobulbar tract. And after decussation, cross fibers and uncrossed fiber or lateral corticospinal tract and anterior corticospinal tract, which will be there in a spinal cord, lower part of medulla and spinal cord. So if you get the damage in cortex, you will have opposite half of the body getting involved. We'll label that as a contralateral hemiplegia. So it will be hemiplegia on the opposite side. As you come down after crossing, if you get the damage in pyramidal tract, that will be same side, we call ipsilateral hemiplegia. But at the level of the damage, either in the medulla or in the spinal cord, at the level we will have a low motor neuron type of a palsy, and below the level we will have a upper motor neuron type of palsy. So below the level we will have a upper motor neuron type of palsy, and at the level, because of the damage to the anterior horn cell, we will have a low motor neuron type of palsy. That will be ipsilateral, and you will have a ipsilateral upper motor neuron below the level of damage. That will be very peculiar. So that we must remember. So whenever we label, say here the person has come with forelimb weakness, so we'll first put that the person is having quadriplegia. Now all the four limbs are involved, and it is below the C5. There is a due to spinal cord lesion above C5. So it is a spinal cord damage. So cervical spinal cord damage above C5 level. And it is involving pyramidal tract, posterior column, spinothalamic tract due to extradural compression. So physiological diagnosis will be pyramidal tract, spinothalamic tract, posterior column involvement. And final confirmation will be extradural, extramedullary compressive etiology producing quadriparesis at the level of cervical cord. This will be the final diagnosis. So here you can see that there is sudden onset of motor weakness on the right side with global aphasia. Whenever you get a weakness with global aphasia, it has to be a cortex which will be involved. Due to suspected stroke and the lesions which is there, and there is a effect in a language area. So if you look, hemiplegia with global aphasia means it has to be middle cerebral artery territory. So it will be a middle cerebral artery territory. It is a right side damage, so it will be a left cerebral hemisphere. So it will be left middle cerebral artery territory, and it is involving cerebral cortex, that is frontal lobe, parietal lobe. So in frontal lobe, Broca's area; in parietal lobe, Wernicke's area. So in frontal lobe, motor area with Broca's area is affected, and in parietal lobe, Wernicke's area with other associated area will be affected. So final diagnosis will be stroke because it is a vascular involvement. So this will be all four you will have to combine. So person is having left middle cerebral artery involvement, producing hemiplegia with global aphasia, and this will label as stroke. So the most common cause of damage to the pyramidal tract is vascular etiology, which can be embolic or intracranial hemorrhage, which is usually acute onset. While in case of the thrombosis, it is good number of time slow onset and gradually progressive. So there will be difference between the presentation as far as a stroke is concerned. While because of trauma or infection or tumor, this will be not due to stroke. We call stroke is because of a vascular involvement. So those will be the causes which will produce a damage to the pyramidal tract because of non-stroke or non-vascular etiology. Now whenever it produces a damage, it can produce different types of involvement at different levels. So just I'll be mentioning few of those. If you get a cross hemiplegia, that is contralateral, so there will be damage to the right side cerebral hemisphere or subcortical region or right side, say internal capsule. You will have left side hemiplegia. So that is called crossed hemiplegia or contralateral hemiplegia. Uncrossed hemiplegia means ipsilateral if you get a damage after crossing of a corticospinal tract, that is at the lower part of medulla and then in the spinal cord. We usually use the word spinal hemiplegia. So in a spinal it is an uncrossed hemiplegia. Cruciate hemiplegia means, say there is an upper limb involvement on ipsilateral side and lower limb involvement on a contralateral side. This will happen when there is a damage at the junction of lower part of a medulla and junction of lower and upper part of medulla, where fiber of both sides are crossing, and if we get the damage at that side, we can have upper limb involvement on the same side and opposite side lower limb involvement. These two things can happen, and then we label that as a cruciate hemiplegia. If person is having total power 0, we call that as a hemiplegia, and if there is little power preserved, we'll call that as a hemiparesis. If you get the damage to cerebral cortex or subcortical region during prenatal or during natal or after delivery, postnatal period, we label that as cerebral palsy, and in that we can have three varieties of stroke. Ideally we don't call stroke, but we call cerebral palsy, which can be spastic variety because of damage to the pyramidal tract as well as damage to the basal ganglia. We can have ataxic cerebral palsy, which will be because of the damage to cerebellar hemisphere, and we can have a dyskinetic cerebral palsy, which will be due to damage to basal ganglia. But this can mimic identical like hemiplegia, and you can come across spastic hemiplegia because of damage to pyramidal tracts. Now if there is a damage in the internal capsule, we'll be coming across with a dense hemiplegia along with But this hemiplegia will be affecting opposite side of the body. We'll have crossed hemisensory loss. We'll have opposite side homonymous hemianopia. And also we'll have bilateral auditory involvement because of damage in the internal capsule, because all those fibers are very compact in internal capsule. Now if we get upper limb more involved as compared to lower limb, we use the word brachial hemiplegia, and this will happen very frequently if there is a damage in the midline close to the superior sagittal sinus, either because of superior sagittal sinus thrombosis or unpaired anterior cerebral artery damage. We can have sometime bilateral lower limb involved, but sorry, that will be cruel hemiplegia. Lower limb, if it is more involved, it will be a midline lesion or damage to anterior cerebral artery which supplies the medial surface of the cerebral cortex, involving lower limb more as compared to upper limb. Then we label that as a crural hemiplegia. And if there is a damage in the middle cerebral artery territory, upper limb will be more involved as compared to lower limb. Then we use the word brachial hemiplegia. Now if we get the damage in the brainstem, either in the midbrain, pons or medulla, upper part of medulla, we'll have ipsilateral lower motor neuron cranial nerve palsy, and opposite side hemiplegia we call crossed hemiplegia. But this will be contralateral, means ipsilateral lower motor neuron cranial nerve palsy with opposite side hemiplegia. While in a classical, what we call is a contralateral hemiplegia, which is also used the word crossed hemiplegia, where you got a damage on one side either in the cerebral cortex or coronary radiata or internal capsule, and you got opposite side hemiplegia with upper motor neuron facial and upper motor neuron hypoglossal. That is also, we use the word cross hemiplegia because there is a opposite side of the body is being involved. So these are all the different terminology which you utilize, and by and large we can easily put the probable localization. That is very simple. There is one word which is a hereditary, we call alternating hemiplegia or familial hemiplegia, where person develops hemiplegia, recovers and again can develop hemiplegia. This is seen in family, so it is called familial or genetic. And once in a while we come across what we call as a psychogenic, or we call hysterical, where there is no damage to cerebral central nervous system, but person mimics hemiplegia, which will be very easily differentiated by what we call as a test, which you try to differentiate between true and false hemiplegia. Now, hemiplegia can be of a two variety. One, where we develop an acute flaccid hemiplegia if there is an acute insult or acute damage like intracranial hemorrhage or massive embolism. Because of an acute damage, there is hypotonia, hyporeflexia, plantar not elicitable or plantar absent. And once the person starts recovering, the person will have a spastic hemiplegia, where you will have an increased tone, deep tendon reflex will be brisk, so bicep, tricep, supinator, knee and ankle will be brisk, and you will be able to demonstrate clonus in ankle as well as patellar clonus. Plantar reflex will be extensor, we call that as a Babinski sign positive, or we call Babinski reflex or Babinski sign. In upper limb, you can demonstrate similar like Babinski sign. They are called upper limb Babinski sign, like Hoffman test, Wattenberg test, and finger flexion test will be demonstrable. So those will be positive. There will be no wasting, no fasciculation, but power will be diminished. Depending upon the power diminished, if complete power gone, it will be hemiplegia, and if there is a partial decrease in the power, we'll label that as hemiparesis. And this can be easily identified by doing what we call as fast, that is face, arm and speech examination, a quick examination, or there is another way we call be fast, that is eye, face, arm, speech, and also during time period. If you get the damage at the cortex or internal capsule or the brainstem, you will have spastic hemiplegia because it will be upper motor neuron. But in a spinal cord, at the level of damage, whatever anterior horn cells are involved, you will have a lower motor neuron type of a palsy. Pyramidal distribution of weakness will be there. Upper limb will be flexed at elbow. Fist will be closed. You will have adduction of the thumb, and lower limb will be extended and adducted. Asymmetrical reflexes will be present because on the side of the damage you will have exaggerated reflexes or brisk reflexes with clonus present. Plantar will be extensor and person will have a classical circumduction gait. In spinal cord, at the level of damage, lower motor neuron, above the level of damage, cranial nerve will be spared, and there will be no involvement of cranial nerves in midbrain, pons and medulla because there is a damage at spinal cord level. And below the level, you will have upper motor neuron. Depending upon the involvement, you can have a monoplegia, you can have a paraplegia, spinal cord lesions, and peripheral lesions. This will not be a part of stroke. Usually, monoplegia will be very frequently because of peripheral nerve lesions or plexus lesion, and occasionally because of vascular etiology. That can be there if there is a involvement of an anterior cerebral artery or middle cerebral artery, a small branch. While paraplegia will be very frequently because of peripheral nerve damage or total spinal cord transection like transverse myelitis or complete transection. Spinal cord lesions can produce by compressive or a non-compressive lesion. Below the level will be upper motor neuron and at the level it will be lower motor neuron. And in a peripheral nerve damage, either root or plexus or nerve or myoneural junction, it will be always lower motor neuron. Depending upon the amount, if one limb is involved, whether it is lower limb or upper limb, it will be monoplegia. If one side is involved, hemiplegia, which may be with face involvement or without face involvement. If face is involved on the same side and upper motor neuron variety, it will be due to damage to opposite side cerebral cortex. And classical example of that will be either damage to cerebral cortex or coronary artery or internal capsule up to we call pons. Very frequently, if we get a damage in the brainstem and if it is in the pons, same side you will have lower motor neuron palsy and opposite side you will have hemiplegia. This will call as a crossed hemiplegia. So it will be very characteristic. If we come across all four limb involved and sparing face, it will be because of cervical cord damage or lower part of brainstem. And that will result into what we call as a quadriplegia or tetraplegia. Now we have got three main sites: cerebral hemisphere, brainstem and spinal cord. And among cerebral hemisphere, we can divide into cerebral cortex, subcortical region, internal capsule. This will be the three portion where we can localize. And in a brainstem, midbrain, pons and medulla. And after the lower part of medulla, damage will occur in cervical spine above C5, then we can have hemiplegia. So if there is an hemiplegia, simple diagram is shown here. Say if you get an hemiplegia on one side with upper limb and lower limb involved and lower half of the face, upper motor neuron type of facial palsy, it will be due to opposite side, cerebral cortex, corona radiata or internal capsule. But if we come across one side lower motor neuron type of facial nerve involvement and opposite side hemiplegia, it will be only if there is a damage in brainstem. Now for this particular thing, you have to have a damage in pons, lower part of pons. Then only we can get lower motor neuron type of a facial nerve palsy, and we can have opposite side hemiplegia. This will be possible only if we get the damage in lower part of the pons. So here suppose if there is a damage to this side, then we'll have the same side lower motor neuron facial and opposite side, because the fiber crosses to the opposite side and then it supplies upper limb and lower limb. So that will produce classical, this pattern we call as a crossed hemiplegia. And once it comes to the spinal cord, it will be same side hemiplegia, upper limb and lower limb involved, sparing face and all cranial nerves, and you will have a clear-cut sensory level. And in that damage, you will have peculiar presentation we will be mentioning further. So in a spinal cord damage, same side and there is no cranial nerve palsy, sparing face. In a brainstem, contralateral hemiplegia and lower motor neuron cranial nerve palsy on the site of the damage. As far as cerebral hemisphere, that is cerebral cortex, corona radiata or internal capsule, opposite side upper motor neuron facial, upper motor neuron 12th cranial nerve, and you might have homonymous hemianopia, particularly if you get the damage in internal capsule. So repeating again, now we are going through different portion. So if there is a damage to cerebral cortex, you will have altered level of consciousness, abnormal cognitive functions, person can develop seizures, and you will have an opposite side, sensory as well as motor involvement, because both sensory input is coming from the opposite half of the body and pyramidal tract is innervating opposite half of the body. And you can have involvement of head as well as upper limb and lower limb, because the fiber of optic nerve do enter through internal capsule and then innervate, then it ends in the occipital cortex. They can be involved, particularly when you get a damage in the internal capsule and you can get opposite side homonymous hemianopia. So you can have a visual field abnormality. And if we get outside the internal capsule, we can have Mayer's loop or Bum's loop getting involved, and we can have a quadrantic field loss. If we get a basal ganglia involvement, which are the deeper structures, we can have a movement disorders like involuntary movement, particularly we can have a chorea, athetosis, etc. or tremors. So depending upon the area involved, we can have, if we have got a frontal lobe involvement and dominant hemisphere, we can have a Broca's aphasia with motor involvement. If we have got a parietal lobe involvement, we can have a Wernicke's area with sensory involvement. And if we have got a non-dominant hemisphere where frontal lobe as well as parietal lobe is involved because of a MCA territory, we can have what we call as Gerstmann syndrome, where the person will have a finger agnosia, alexia, agraphia, along with person will not be able to differentiate right and left. We call side, person cannot identify, that is we call agnosia, finger agnosia will be there. This is combined together labeled as Gerstmann syndrome. So depending upon which area is being involved, Suppose if you get the involvement of the anterior cerebral artery, you will have involvement of the lower limb more along with bladder control. If we have got a MCA territory, you can have involvement of the frontal lobe, and if a frontal lobe is involved, we can have even a involvement of a gaze palsy, particularly horizontal gaze palsy. And when MCA is involved, we can have frontal lobe, parietal lobe and temporal lobe getting involved. And if we have got a posterior cerebral artery, you can have occipital lobe involvement, and we can have a homonymous hemianopia with macular sparing. So this will be all involvement in case of a cerebral hemisphere. So this is the area: frontal lobe, this is parietal lobe, this is temporal lobe, this is occipital lobe, and we should be aware of which portion is supplied by which artery. So we'll be showing you that this is middle cerebral artery, this is anterior cerebral artery, this is posterior cerebral artery. So if we get MCA territory and this is superior branch, this is inferior branch. If inferior branch is involved, we'll have more of frontal lobe and Broca's area involvement. If we have got a superior branch, we'll have a Wernicke's area and parietal lobe, and we can have involvement of also temporal lobe. And when big main branch of MCA is involved, then we can have entire this lobe. Person will have a global aphasia with motor and sensory of opposite side being involved. While anterior cerebral artery will have a lower limb more involved as compared to upper limb. We call differential hemiplegia. So more of lower limb sparing upper limb and face and arm. That will be without aphasia, whether no motor aphasia, no Broca's aphasia. And if we get a posterior cerebral artery involved, we'll have a more of homonymous hemianopia with macular sparing. And when bilateral involvement, we can have a cortical blindness. So ACA territory, opposite side, lower limb involved more with frontal lobe, portion of frontal lobe, and in that we can have involvement of frontal eye field, and we can have a horizontal gaze palsy. MCA territory, opposite side hemiplegia with opposite side hemianesthesia and global aphasia. Also, because of involvement of a internal capsule which is supplied by the branch of middle cerebral artery, we call penetrating branch, or we call striate arteries or Charcot's artery, that is called Charcot artery. And if that is being involved, we get opposite side dense hemiplegia, opposite side hemianesthesia, along with there will be no global aphasia when penetrating branch are involved and involving internal capsule. So you will have mainly opposite side hemiplegia, opposite side hemianesthesia, opposite side homonymous hemianopia, and you will have a loss of hearing, that is auditory portion will be involved. And when we get a posterior cerebral artery involved, cerebellum with homonymous hemianopia, and upper part of a midbrain will be also involved, involving third cranial nerve we can get. And if internal carotid artery is involved, you will have a mixed picture of MCA with ACA, that is opposite side hemiplegia, opposite side hemianesthesia with global aphasia. And you can have other area also getting involved, like Wernicke's area, and associated area will be producing alexia, agraphia, acalculia, cortical sensory loss, etc. So that will be very, very important. And particularly when you get involvement of this particular portion, you can have a lower limb involved, you can have rigidity, it is labeled as Jacob-Halton rigidity, that will be very peculiar in lower limb with bladder involvement. So you will have a these are all the different areas where you can get involvement. So Gerstmann syndrome will be hemi-neglect, apraxia, acalculia, agraphia, and person will have a right and left confusion. Person will not be able to identify what is right, what is left. and even he will have finger agnosia. That is labeled as a Gerstmann syndrome, which will be in a non-dominant hemisphere. And in a case of a dominant hemisphere, you will have a Broca's with Wernicke's aphasia. Even optic radiation may be also involved. And you will have a face, neck and upper limb more involved as compared to lower limb. So we call that as a differentiated. And because of involvement of the cortex, person will have a very commonly seizures will be very common. Person will have a raised intracranial pressure producing headache, vomiting, disorientation. We have already mentioned global aphasia. And upper limb will be more involved as compared to lower limb. We call differential hemiplegia. And that will be more common with MCA territory. And in case of a ACA territory, we'll have a lower limb more involved as compared to upper limb. So indirectly in a cortical stroke, contralateral hemisensory loss. Contralateral hemisensory loss of the face also will be there. Contralateral hemiplegia, that is motor involvement. We'll say that horizontal gaze palsy, and because of the damage, left side brain stroke will deviate the eye to right side. We call opposite side. So eye will deviate to the opposite side. And if there is an MCA infarct, it will produce Wernicke's as well as Broca's aphasia, we call as a global aphasia. And if it is a dominant hemisphere, and we have told you that if it is a non-dominant hemisphere, person can have hemi-neglect, motor and sensory findings, mainly in upper limb, and you can have even upper or lower quadrantic homonymous hemianopia depending upon which part is being involved. In a ACA territory, you will have lower limb more involved, involving both motor as well as sensory. While in a posterior cerebral artery, you will have a contralateral hemianopia with macular sparing. This will be a peculiar distribution in a cortical damage. And we have already mentioned regarding all the three territories, that is MCA, ACA and PCA. So we have got a contralateral hemiplegia, cortical sensory loss. Invariably person will have altered level of consciousness and seizures are common. We have already mentioned all those things. So they say that 4C. So these are 4C with raised intracranial pressure, global aphasia and differential hemiplegia. So upper limb more involved as compared to lower limb in MCA, lower limb more involved as compared to upper limb in case of ACA territory. And in case of a PCA, upper limb, lower limb are spared. There is mainly homonymous hemianopia with macular sparing. And if we come across, we have already told you, non-dominant hemisphere, Gerstmann syndrome, that is acalculia, agraphia, and finger agnosia with right and left. Person will not be able to differentiate between right and left. He'll also have alexia, tactile agnosia, that is we call as a cortical sensory loss. And person will also have sensory aphasia, which is because of the involvement of parietal lobe area. That will be more common with non-dominant hemisphere. So we have already mentioned in cerebral cortex, opposite side motor weakness with LOC, motor aphasia, cortical sensory loss, orientation is affected, memory is affected, opposite side sensory loss, homonymous hemianopia, gaze palsy, seizures. And if you come across hemiplegia with cranial nerve involvement, mainly it will be either ipsilateral or contralateral. If it is ipsilateral, lower motor neuron cranial nerve palsy with opposite side hemiplegia, it has to be in a brainstem. If third cranial nerve with opposite side hemiplegia, upper part of midbrain, fourth cranial nerve with opposite side, lower part of midbrain, and 5, 6 and 7, it is will be in a pons. But if it is upper motor neuron on the side of the hemiplegia, it will be always above the midbrain. either in cerebral cortex or corona radiata or internal capsule. So lower motor neuron, it has to be in a brainstem lesion. And upper motor neuron lesion in 7th and 12th cranial nerve, by and large above the midbrain. And if there is a homonymous hemianopia with hemiplegia, internal capsule. And in an internal capsule, along with that, you will have a homonymous hemianopia of opposite side and you will have a bilateral auditory gone. So hearing disturbance is bilateral. If any person who comes with a multiple cranial nerve palsy, always suspect poliomyelitis, GBS, motor neuron disease, and once in a while in case of multiple sclerosis. Whenever there is a brainstem damage, it can be because of vertebral artery or basilar artery, or we call vertebro-basilar artery. You can have an anterior spinal artery involvement which can produce anterior 2/3 of the spinal cord involved, producing motor signs and lateral column signs, sparing posterior column. If basilar artery is involved, it will be mainly involvement of the pons. If vertebral artery is involved at the junction of vertebro-basilar territory, it will be more of upper part of the medulla getting involved. And if posterior cerebral artery and branches are involved, it will be occipital lobe, cerebellum and midbrain. And again, at the level of cerebellum, it can be anterior inferior cerebellar artery or posterior inferior cerebellar artery, and that will be involving more of cerebellum. We are not going into that brainstem localization. Inner cortex, we already mentioned regarding MCA, ACA and PCA territory. Whenever you get a damage to parietal lobe, you can have apraxia, acalculia, agraphia and agnosia, which will be most common with superior branch of a middle cerebral artery. And if it is a non-dominant hemisphere, you can have even hemi-neglect. If there is an involvement of the subcortical, that is we call corona radiata, you will have a differential involvement, that is you can have only one limb more involved as compared to other limb, like upper limb only involved or lower limb involved, depending on which part of the corona radiata is involved. Or you can have lower limb more involved than upper limb and upper limb more involved as compared to lower limb, depending upon which part, anterior or we call lateral or medial side of corona radiata. But one characteristic which differentiate from cortex, there will be no seizures, there will be no global aphasia or motor aphasia or sensory aphasia, or we call Wernicke's aphasia. And by and large, person will not have any altered level of consciousness. So these three findings helps to differentiate from a cortical lesion. In a cortical lesion, seizures will be more common, motor aphasia or Wernicke's aphasia or global aphasia will be more common, and very common altered level of consciousness. Altered level of consciousness will be also seen if there is a damage to pons and medulla, where reticular formation we call as activating reticular system. If it is involved, person can also have an altered level of consciousness if there is a brainstem lesion in a pons and upper part of medulla. So that will be the area where you can have also altered level of consciousness. Also, in case of an internal capsular damage, will have no seizures, no aphasia and no altered level of consciousness. But when you get a damage in internal capsule, we'll have a dense hemiplegia, upper limb and lower limb equally involved with hemisensory loss, homonymous hemianopia and 8 cranial nerve, that is auditory radiation involved. We'll have a bilateral hearing disturbances. So in an internal capsule, dense hemiplegia, upper limb and lower limb equally involved. No speech, that is particularly aphasia. But because of involvement of facial, that is upper motor neuron facial and 12th cranial nerve, you will have a dysarthria, no convulsions, and only upper motor neuron 7th and upper motor neuron genioglossus involvement. will be on the side of hemiplegia. So that will be very peculiar, that is dense hemiplegia with no aphasia but dysarthria, no convulsions. That is characteristic, and it is very frequently by a branch from what we call as an MCA territory, we call as a Charcot's artery, or we call penetrating artery, or lenticulostriate artery. These are the different names which are being given. So end artery, a branch of MCA, also labeled as Charcot's artery. You will have spastic hemiplegia of opposite side, with opposite side lower half of the face involved. Plantar extensor, very characteristic, with even genioglossus getting involved whenever you get internal capsule. So contralateral dense hemiplegia, hemisensory loss, upper motor neuron facial, homonymous hemianopia will be characteristic. So contralateral hemianesthesia will be very, very common. Complete half of the face as well as half of the body will be very peculiar if you get a damage in the internal capsule. Very characteristic. But if you get a damage, one side sensory loss and lower and opposite side hemisensory loss will be more common if you get a damage in the brainstem, particularly in the pontine region. We call crossed hemianesthesia. Contralateral homonymous hemianopia will be again very common with we call as damage to internal capsule, and bilateral diminished hearing acuity will be again because of the damage to auditory radiations. When you come to the brainstem, we already mentioned cranial nerves will be involved. Mainly at the level it will be lower motor neuron. Above the level cranial nerves will be normal, and below the level you will have upper motor neuron cranial nerves, particularly facial and genioglossus. That will be very peculiar. And you will have a opposite side hemiplegia and opposite side sensory loss. And because of cranial nerve involvement, you can have a dysarthria, diplopia, dysphagia, etc. And inner pons and medulla, because of involvement of activating ascending reticular activating system, you will have an altered level of consciousness. That is very common with pons lesion and upper part of medulla. We already mentioned all this because all cranial nerves are bilaterally innervated except lower half of the face on opposite side and genioglossus of opposite side. That is unilaterally innervated by opposite side corticobulbar tract. In summary, we have already mentioned these findings. So in a brainstem lesion, contralateral hemisensory loss, contralateral hemiplegia very, very peculiar, with ipsilateral cranial nerve loss, which is not present in cortical. In cortical, it will be same side, lower half of the face and genioglossus. Ipsilateral horners will be very commonly seen if there is a damage to the we call as a lateral medullary syndrome. Ipsilateral horner syndrome, ipsilateral pupil involvement like meiosis, ipsilateral ptosis, anhidrosis, etc. This will be peculiar in a horners. That is, and you can have lateral pontine damage, you will have a ipsilateral facial nerve involvement, and along with that you can have a medullary nucleus involved, that is 9th and 10th cranial nerve, producing dysphagia and absence of gag reflex on that side. So in a case of a bulbar palsy, which is a progressive bulbar palsy involving the motor cranial nerve nucleus, it will be producing flaccid dysphagia, flaccid dysarthria, fasciculation will be present, there will be wasting which will be very early, you will have a labile effect, gag reflex will be absent, jaw jerk will be absent. While in a case of a bilateral upper motor neuron, which is because of the damage to bilateral corticospinal tract, due to multiple strokes. You will have a spastic dysphagia, spastic dysarthria. You will have what we call as a labile effect will be present because of damage to simultaneously frontal lobe. Fasciculation is usually absent because there is no atrophy. You can get disuse atrophy in a late stage. Gag reflex will be brisk, jaw jerk will be brisk. This will be a very peculiar finding in a pseudobulbar palsy where we get bilateral hemiplegia. So that will be very characteristic. So in a cortical damage, upper motor neuron. In pseudobulbar palsy, bilateral corticobulbar tract damage. In a pons, very frequently we'll get a lower motor neuron, particularly in a case of a bulbar palsy, and we'll have a bilateral lower motor neuron involvement. And below the medulla, we can have involvement as anterior horn cell getting involved, we'll have a lower motor neuron type of a palsy. So in a spinal cord, we'll have a clear-cut sensory level that is a very peculiar which can differentiate from all other. We'll have a back pain, we'll have tenderness because of involvement of the spinal cord and vertebra. We'll have motor and sensory on the same side. You will have a mixed upper motor neuron as well as a lower motor neuron finding, meaning at the level of damage, we'll have a lower motor neuron finding, and below the level of the damage on the same side, we'll have a upper motor neuron finding. We'll have a clear-cut sensory level, and if it is a Brown-Sequard syndrome, we'll have a peculiar distribution that is on the side of the damage. We'll have a posterior column gone. So you will have a posterior column findings on the same side and opposite side spinothalamic tract gone. So opposite side pain and temperature gone, and same side loss of vibration, kinesthetic sensation and joint sensation and crude touch. That will be very peculiar. And if there is a damage in the S2, S3, S4, we'll have a bladder and bowel involvement, very, very common. And if it is a complete transection, we'll have bladder and bowel involvement, more common. So very peculiar, and particularly in case of a spinal cord damage, at the level we'll have a classical lower motor neuron finding in the form of wasting, fasciculation, reflexes will be absent at the level, and we'll also have a complete sensory loss, total sensory loss on the side of the damage. This will be very, very peculiar. Lower limb will be involved if there is an involvement of a lumbosacral plexus. Upper limb will be more involved if there is an involvement of the brachial plexus. So in a case of a Brown-Sequard syndrome, we have already mentioned, we'll have a lateral spinothalamic tract of opposite side, and same side we'll have a posterior column gone, so loss of fine touch and proprioceptive sensation, that is joint sense, vibrations and kinesthetic sensation. And below the level, upper motor neuron findings. At the level, lower motor neuron findings. And opposite side, you will have a pain and temperature gone. That will be very peculiar finding in a case of a hemisection, or we call it a Brown-Sequard syndrome. While complete transection, below the level, you will have all sensory gone and motor gone. Very characteristic. And at the level, lower motor neuron. So that will be very peculiar. And above the level, no cranial nerve involvement. And face will be spared. So if you have got a cord lesion, complete transection at the above C5, we'll have a quadriplegia. And if it is hemisection, we'll have hemiplegia. So this is, now we are going through hemiplegia. So upper limb, you will demonstrate pronator drift, and you will have peculiar findings in upper limb, that is you will have a upper motor neuron lesions, that is bicep tricep supinator will be brisk. In lower limb, knee and ankle will be brisk, and you will be able to demonstrate ankle clonus and patellar clonus. We'll have a crossed hemiplegia if there is a damage at the level of brainstem. Particularly, we'll have cranial nerve involvement as far as the facial and hypoglossal is concerned. Both will be upper motor neuron if there is a damage above the brainstem, and if there is a damage below the brainstem, we'll have a cross hemiplegia in the form of lower motor neuron cranial nerve palsy. On the ipsilateral side and opposite side, we'll have spastic hemiplegia. So that will be very, very peculiar. Depending upon the cranial nerve involvement, we'll be mentioning those findings, and we'll have typical circumduction gait. Speech disturbances will be very common if it is on a dominant hemisphere and cortical damage. If it is a frontal lobe involvement, we'll have a Broca's aphasia. If it is a parietal lobe involvement, we'll have a Wernicke's aphasia. And we'll have a typical circumduction gait, that is uni-scissors gait. We can screen them by a FAST because the face, arm and speech, and T is for times. So in acute, we can have a flaccid hemiplegia and can be due to a shock stage, and later on we'll have spastic hemiplegia. So in case of a cortical, we have already mentioned previously, we will have aphasia, altered level of consciousness, and seizures will be more common. And you can have differential hemiplegia, means upper limb more involved as compared to lower limb in case of a MCA territory, and lower limb more involved as compared to the upper limb in case of a ACA territory. And we have already mentioned regarding all these cranial nerves, what will happen, etc. Already we have mentioned that in internal capsule, we'll have involvement of a contralateral sites. Also in a case of a brainstem, also we'll have a contralateral hemiplegia. And as far as if we take in an internal capsule on the side of hemiplegia, we'll have upper motor neuron facial and upper motor neuron genioglossus. That's why we call that as uncrossed hemiplegia, but it is a contralateral. While in a case of a brainstem damage, we'll have same side, that is ipsilateral, lower motor neuron cranial nerve palsy, and opposite side hemiplegia. So we usually commonly use the word cross hemiplegia. So ideally when we say regarding cortical internal capsule, corona radiata, we should use the word contralateral hemiplegia, while in a brainstem it will be crossed hemiplegia, and particularly in a case of a junction of upper part of a medulla and lower part of medulla, we can have crural hemiplegia, means upper limb involved on ipsilateral side and lower limb of opposite side. And if we have got upper limb more involved as compared to lower limb, brachial hemiplegia is used, and if lower limb is more involved as compared to upper limb, crural hemiplegia is being used. And if you have got one side upper limb and opposite side lower limb, cruciate hemiplegia. So these are all the different terms. We have already mentioned all this. Cortical, brainstem, spinal cord, that is particularly Brown-Séquard syndromes, we have already mentioned. Site-wise, you can diagnose by cortical, capsular, brainstem. We have repeatedly mentioned all those things. By sensory loss and cranial nerve examination, particularly 7th and 12th cranial nerve, we have already mentioned. And this will be a peculiar presentation in a cerebrovascular stroke, or we call as a stroke. What finding will be there? In general, all those we have mentioned, that headache, altered level of consciousness, Broca's aphasia or global aphasia or Wernicke's aphasia. Person can have difficulty in swallowing, cough reflex. You can have finger agnosia, incontinence, seizures, etc. can be there. And on a hemiparetic side, you can have emotional lability, visual disturbances like homonymous hemianopia. Person can have vomiting, etc. because of raised intracranial pressure. this will be all together finding, combined finding. And for localization, we have already mentioned majority of the things. This is a difference between myopathy, neuropathy, anterior horn cells. I've already discussed in differential diagnosis in other groups. You can go through at leisure time. So this will be difference between myopathy, anterior horn cell, peripheral neuropathy and neuromuscular junction, particularly in a first approach to CNS lesion, that is pattern wise. We have already mentioned in these differences. Now, if there is a lesion at number 1, what will be the finding? It will be hemiplegia with upper motor neuron facial. That will be very peculiar, particularly if you got a damage here. So in 1, that will be finding. Here you will have upper limb more involved as compared to lower limb. So in this at 1, you will have monoplegia, particularly lower limb involved. In 2, you will have upper limb and face being more involved. But when you get 1 and 2 together, it will be hemiplegia plus upper motor neuron facial. And if you get the damage at 3, you will have internal capsule involved. So you will have a hemiplegia. Sorry, it is not mentioned here. So it will be hemiplegia with hemianesthesia, with homonymous hemianopia, and also with auditory fiber gone. In 4, you will come across hemiplegia with lower motor neuron cranial nerve palsy. We will call that as a crossed hemiplegia. And in 5, it will be spinal hemiplegia. But if it is above C5, quadriplegia, if it is complete transection, and if it is below C5, no, it should be paraplegia, should be below T1 level. Sorry, this is not mentioned here. It is showing you here, that is paraplegia. Sorry, something wrong. So paraplegia with upper limb involved. Where is the lesion? You will have to put that together. Now, first step, always identify whether facial nerve along with hemiplegia, whether it is lower motor neuron or upper motor neuron. So you can pinpoint whether it is in the pons or whether it is above the pons. If it is lower motor neuron, at the level of pons, and if it is upper motor neuron, above the pons. So it will be very, very important. And then look at the oculomotor nerve. If oculomotor nerve is affected and contralateral to the side of hemiplegia, then lesion has to be in a midbrain. So facial nerve involvement examination will be very, very important. And we have already mentioned that in internal capsule you will have a dense hemiplegia, and in a corona radiata you will have a sparing effect, so you can have a one limb more involved as compared to other limb, or we call differential hemiplegia. And if it is a cortex involvement, we have already mentioned, you will have altered level of consciousness, seizures, Wernicke's aphasia, Broca's aphasia, etc. So if it is there is a damage in the medulla, you will have more of 9th, 10th, 11th and 12th cranial nerve involved. And particularly you can have motor neuron disease, which can be of multiple different variety, like amyotrophic lateral sclerosis, where upper motor neuron and lower motor neuron will be combined lesion. So anytime if you see both findings together, upper motor neuron and lower motor neuron, you suspect amyotrophic lateral sclerosis. If you get pure upper motor neuron bilateral, suspect pseudobulbar palsy. If you get more in lower limb involved, suspect primary lateral sclerosis. If you get bilateral lower motor neuron of brainstem cranial nerve involvement, suspect progressive bulbar palsy. And if you get lower motor neuron involvement in a spinal cord region, suspect progressive spinal muscular atrophy. This will be in a amyotrophic lateral sclerosis. But if you get at the level only lower motor neuron and at the level there is no other upper motor neuron findings, and below the level of the damage you get upper motor neuron finding, it is not due to motor neuron disease. It will be very frequently either a compressive lesion or a non-compressive lesion, intramedullary, extramedullary, or maybe because of transverse myelitis, etc. So you can have a motor loss and sensory loss on the same side, particularly we call as the opposite side, contralateral side of the damage in a cortex, internal capsule or corona radiata. Along with we get, so if always try to identify whether it is upper motor neuron or lower motor neuron. Upper motor neuron you will get in cortex as well as corona radiata, internal capsule, right up to anterior horn cell. While lower motor neuron findings will be if there is a damage to anterior horn cell or if there is a damage to motor cranial nerve nucleus in brainstem, or there is a muscular involvement, muscle involvement. And particularly in case of a cortex up to medulla, it will be always opposite side. In a lower part of medulla and spinal cord, it will be ipsilateral. In a brainstem, there will be contralateral, means on the side of the damage, lower motor neuron, cranial nerve palsy, and opposite side, hemiplegia, which will be of upper motor neuron variety. So this combination, permutation combination gives you a very good idea regarding localization of lesion. Always remember that upper limb is C5 to T1 and lower limb is lumbar 1 to S2. So this will be a brachial plexus, this will be lumbosacral plexus. And depending upon that lesion, you can give involvement of the upper limb and lower limb alone if there is a damage to plexus or peripheral nerves. So you can have a different type of lesions like monoplegia, hemiplegia, crossed hemiplegia, quadru, brachial, paraplegia. Peripheral nerve involvement, sensory nerve involvement, motor involvement, reflexes, trophic changes. So in a peripheral nerve damage, sensory findings will be there, motor will be lower motor neuron, reflexes will be absent, and trophic changes will be there because of sensory involvement. When you get sensory plus motor involvement and completely lower motor neuron type of damage, you will suspect either in the plexus or in the peripheral nerves or at the myoneural junction, and in a myoneural junction sensory finding will be absent. So if sensory finding is not there and you get a lower motor neuron type of a motor involvement, do suspect muscle or myoneural junction, that is myopathy or myoneural junction. Here you can see that this is pure one limb involved, so this is monoplegia. This can be in a cerebral cortex or can be in a spinal cord. In cerebral cortex also it will be more common. This is lower limb involved, so it will be ACA territory. And you can have also due to involvement of peripheral nerves. So in cerebral cortex, ACA territory, it can be also involvement in a corona radiata, but less likely to be in a internal capsule. In spinal cord, it will be damaged at the level of lumbar. So right from lumbar 1 onwards on the same side. So as this is what we call is the right side, so it will be a right side of the spinal cord involvement. So it will be Brown-Sequard syndrome, we call as a hemisection, or you can get in a peripheral nerve mononeuritis multiplex. very odd condition. Or you can get involvement of a anterior horn cell in case of a poliomyelitis. So right lower limb monoplegia. So this will be the different possibilities in this particular case. Here you can see that the same side, lower half of the face and upper limb and lower limb involved. So this will be classical, what we call as a contralateral hemiplegia. So maybe in a cerebral cortex, less likely to be in a corona radiata, can be in internal capsule. So internal capsule is more likely, and if it is in internal capsule, we'll have upper limb more involved as compared, both upper limb and lower limb equally involved. We call it a dense hemiplegia, dysarthria, no aphasia, no convulsions, and we'll have upper motor neuron facial and upper motor neuron 12th cranial nerve palsy, along with homonymous hemianopia of opposite side, and on the side of hemiplegia we'll have a hemianesthesia, and we'll have also bilateral auditory damage. This is bilateral involvement of entire body, upper limb, lower limb as well as face. So this will be possibility in cerebral cortex, can be internal capsule, can be bilateral involvement, and midbrain also can be in the pons also. So quadriplegia with bilateral facial, and if we have got one side face involved with opposite side, this has to be only in brainstem. So crossed hemiplegia possibility is only in brainstem. We have already explained that if you get complete lower motor neuron facial, it has to be in pons. This is what we call as typical finding in upper limb involvement. We call jacket type of a sensory loss. This will be classical in syringomyelia. So this is crural diplegia or bilateral brachial, that is upper limb. So it is described as a crural diplegia, and this will be very common in cerebral palsy also. And if we get only sensory loss in this particular distribution, more common pain and temperature gone, it will be classical in case of a syringomyelia. Do remember that. This is bilateral below the neck. So this is quadriplegia, sparing face. So this has to be above the level of C5. So quadriplegia, no facial involvement, cervical spinal cord above C5 level. This is bilateral lower limb involvement. So has to be paraplegia. And if we suspect paraplegia, it can be in a cortical damage because of unpaired anterior cerebral artery involvement or superior sagittal sinus thrombosis or midline tumors like Fox cerebri, meningiomas, etc., which can damage bilateral midline cerebral cortex. And as far as the spinal cord, complete transection above L1 level will produce paraplegia. So above L1 level, or even in a conus medullaris lesion. This is what we call as classical sign, which you will be able to differentiate between non-organic and organic. Very common in young female. Say, as for example, here the example is given as a right hemiplegia, variable weakness, resistance to passive movements. Person will have no response to pain. Passive movement will show you that there is preservation of movements, and person will not have complete plegia. Plantar reflex will be fracture and withdrawal. Flickering of the eyelids will be very commonly seen, and Hoover's sign will be positive. So in a Hoover's sign, the person who is having malingering, or we call as organic, or we call hysterical, the lower limb will press over the couch when you ask to uplift the damaged side. That will be Hoover's sign. This is called pseudo hemiplegia, or we call functional, or we call non-organic, or we call hysterical or psychogenic. There is one peculiar findings which we come across, we call Kernohan's phenomena. This happens in a what we call is a raised intracranial pressure. You can have herniation, and in case of a transtentorial herniation, by and large, due to uncal herniation, there is a compression of the corticospinal tract on the same side, which will produce hemiplegia of opposite side. That is most common. But if there is a push, or we call shift of midline, then opposite side corticospinal tract can be compressed against the transtentorium or tentorium cerebelli, which will produce weakness on the ipsilateral side. And this phenomena is called as a Kernohan's phenomena. So do remember that once in a while, in a case person with a raised intracranial pressure and shift of the central part of the brainstem can produce ipsilateral paralysis because of Kernohan's phenomena. So do remember this. This can be false localizing sign. So always remember that. And during uncal herniation, you can have a ipsilateral 6 cranial palsy, quite common. And there is a little difference in a spinal shock and neurogenic shock. In a neurogenic shock, you will have a hemodynamic phenomena, hypotension, bradycardia, etc. will be very common in a neurogenic shock. While in a spinal shock, it is due to acute spinal injury. There will be absence of all voluntary reflexes below the level of injury. So reflexes will be nearly absent. There will be loss of sensation and flaccid paralysis. And after few days, person will have below the level spastic paralysis. And this usually is a transient, and that we call is a spinal shock. So do keep it in mind. Here we do not have hypotension, we do not have bradycardia in case of spinal shock. But in a neurogenic shock, we'll have a loss of vasomotor tone, and because of loss of vasomotor tone, we'll have a hypotension, bradycardia, and there will be changes in regulation of temperature we call poikilothermia. And this may remain for short period and may require emergency treatment because of severe hypotension. So this is a difference between spinal shock and neurogenic shock. Good number of time in both you get hypotension and bradycardia. But in case of a neurogenic shock, we have got more of sympathetic nervous system being affected, and hence we don't have. So you might have to treat hypotension and bradycardia as an emergency, but here for temporary purpose you will have loss of total power, sensation and reflexes below the level of injury. So we'll have a flaccid paralysis which will not be seen in a neurogenic shock. And the most common cause of spinal shock is a peripheral neuronal becomes temporarily unresponsive, while this is because of disruption of an autonomic pathway, which will be very common in a neurogenic shock. Cerebral palsy, I have already mentioned that in cerebral palsy, it is because of natal, prenatal or perinatal damage to brain, particularly in a newborn, and that is permanent non-progressive damage, and it can be spastic variety, dyskinetic variety or ataxic variety, and in that you can have a hemiplegia, monoplegia, quadriplegia, diplegia, etc. multiple different types of presentation, and it can be spastic variety, dyskinetic variety or ataxic variety. So you can have a hemiplegia, diplegia, quadriplegia, you can have a dyskinetic variety, and you can have an ataxic variety. So different types of presentation can be there in a cerebral palsy, which of which 80% of the time it is antenatal causes, like female getting infections like German measles, shingles, or GDM, or toxemia of pregnancy, or RH incompatibility. And during delivery, asphyxia, birth injury, or premature delivery. And in a postpartum, 10% of the cases may be because of hyperpyrexia, CNS infection, or head injury, or severe hypoxia, and very rarely intracranial hemorrhage. So these are some of the investigation which you will have to undergo, and this will be required for localization and identifying the etiology. So investigation will include to identify at the level of cortical level or at the level of spinal. So depending upon what is being involved, you will be undergoing investigation. So I'll end my lecture here. Thank you very much for taking out time. I know that your time is valuable and I appreciate for spending some of the time with me. See you in next lecture. If you like this particular lecture, please don't forget to press button like, subscribe, and you can share with your friends. And if you feel to give any suggestions, please don't forget to give suggestions so that I can improve the quality and material in my lectures. See you in next lecture.